And that's why I make the first picture that is even more general than what Andrea showed us. You can see there's something that is more important than the patient's smile. But since, unfortunately, we can only change the patient's smile, I will focus also my lecture on something that we can do. But if you look at the patient's smile, we really have to look which is the area that is really critical from an aesthetic point of view, not only because the patient is exposing it, but it's also because the area that is the patient is much more aware of. And we cannot only show the patient from the buccal point of view, but also from the lateral point of view. That makes a lot in terms of how the smile of the patient is nice. And since the whole patient and the whole face has already been covered very, very nicely by Andrea before me, I will concentrate on the only thing I'm able to do, that is the soft tissue. And I will make the comparison between teeth and implants in the area that, according to the patient, is the most important from an aesthetic point of view. And for sure, the area, at least from a periodontal point of view, that is much more important for our patient, is obviously the scallop. The scallop, which means the soft tissue margin, which is made of two papilla, one mesial and one distal, and one scallop outline of the soft tissue margin. Then we can discuss how much is important, the buccal aspect, how the soft tissue is in the buccal aspect is important, independently if the patient is exposing it or not, but how much of this is important is variable by patient, from patient to patient. But in our survey, we demonstrated that the patient is really aware of what happens only for about 4 millimeters in apical direction. And we are lucky, otherwise, when the patient has a lot of scars, apically, especially for some orthomaxillofacial surgery, the patient is not aware of what has happened much more apically, and this is very luck for them. But I mean, we should always be able to show all the patient vestibulum in order to see if our work is good enough for our patient, independently on how much the patient is exposing. But now, what is the difference between teeth and implant? And this is something I really consider very, very important for me, because, you know, I think that most of the people in the world have forgotten what is a tooth and how a tooth is made. You know, tooth is made of a soft tissue margin, which covers a bit the cement enamel junction. And then there is a portion of the root that is called supra-bony component of the root. Can you please repeat with me? Supra-bony component of the root. Okay, thank you very much. Because I sometimes this is lost. Because we know that there is the soft tissue margin, we know there is the buccal bone, but we forgot that in the nice girl, in the nice smile, there is a supra-bony component of the root, which is covered only by soft tissue. And this is very different at the level of the implant side, where more or less the implant is placed exactly at the same distance from the soft tissue margin where the buccal bone starts. But the distance between the buccal bone and the soft tissue margin, in the best situation, is at least the same distance of the supra-bony component of the root in the adjacent tooth. So this is the supra-bony component of the root that is lacking here. But the bone is at the same level. Okay? So it's not a problem of bone. It's not a problem of keeping the root to keep the bone. It's a problem to keep the root that is lacking. The root that is from here to here, that is not present anymore, even if you keep the root to keep the bone. Do you understand what I mean? So, how can we substitute in our smile that tissue, hard tissue, which is called supra-bony component of the root, that keeps the soft tissue in that position so that the enamel emerge through the soft tissue so naturally? Is this the role of the bone? Is this the role of the buccal bone? across so many nice girls that I'm sure they don't have the buccal bone close to the soft tissue margin. I'm sure. I will open all your flaps. In this area, we have only soft tissue, and we call it transmucosal zone. And if you have only soft tissue, we have to make fun of biology because in this area, very different from that of the tooth, the soft tissue is not attached to anything. And so the tissue in this area, since it's not attached, can be colonized by plaque. But even if there is some inflammation that is due to plaque accumulation, this inflammation is limited only to an area of the connective tissue comprised between the external and the internal epithelium, so that there is still some connective tissue remaining here that will give stability to the soft tissue margin. That is what the patient is interested in. Scallop. So the stability of the scallop depends on the connective tissue we have in the transmucosal area. But there is a very different between teeth and implant, because the tooth has the supra-bony component of the root that keeps the soft tissue there in that buccal position so that the enamel gets out very nicely. But this is not present at the level of the implant. The bone is there. The bone is there, but it's something that is lagging from here to here. At the level of the tooth, this something is called supra-bony component of the root, which is not present at the level of the implant side, even if you make socket shield. Which portion of the root do you keep in the socket shield? Infrabony or suprabony? That's very important, because if you keep the infrabony, it's not important for keeping the tissue in position. It's the suprabony. So, do you know the difference, dear friends? This is a tooth, my daughter tooth. There is such a good quality of attachment between the tissue and the root that even if the tissue is not so thick, that will remain there very, very stable. And it takes time, it takes a big trauma, it takes a lot of plaque accumulation in order to make this connective tissue attachment to be destroyed. This is completely different from what happens in the adjacent one, where there is no attachment. There is no connective tissue fibers integrating into the root cement. So how can we substitute this area? Can we substitute it with bone? Do we have bone in this suprabony component of the root? I think that the only way we can do it is by adding something that will make this area thicker, so increase the thickness of the connective tissue that support the soft tissue margin, so that the temporary crown, which also keeps space, the connective tissue, but also the covering flap, will make together the same soft tissue thickness that we need at the level of the adjacent tooth to compensate for the lack of the suprabony component of the root. So, yes, this is a very important zone, because despite we have about 5 millimeters of distance between the bone and the ideal position of the convexity of the enamel, we don't need 5 millimeters of connective tissue graft. But this 5 millimeters of space is compensated by temporary crown, yes, connective tissue graft, no more than 1.2, 1.5 millimeters, and flap that is covering the connective tissue graft. And in this way, the buccal aspect of the tooth and implant resemble exactly the same, but one is much, much thicker, and you need to be much, much thicker because one is attached and the other it is not. So when we speak about thickness, when we speak about biotype or phenotype today, are we really sure that what is thick for teeth is thick enough for implants? I don't think so, because if the inflammatory process occupies an area of 1.5 millimeters of connective tissue, it means that the connective tissue at the level of the buccal aspect of the implant should be more than 2 millimeters in order to be sure that this will not recede because it's not attached. So now we look at the profile, because we like also to see patient from the profile. And when you look at the profile, there is a very nice area that we call convexity. And this convexity is so nice that makes the enamel emerge very natural. But once you go for 3.44 millimeters apical, then I don't see any convexity anymore. But if you look what happens more apically to this 3.54 millimeters, the soft tissue goes palatally. But now, I remember that the bone exactly starts 3.5 millimeter distance from the soft tissue margin. So where is the bone, the buccal bone? I don't have any convexity, but I have a slightly concavity in palatal direction. Why? The convexity is where there is no bone. So why do we have to augment the bone in order to give aesthetic to my patient? And so, what is this? Do you like this? This is a case where bone was augmented. And exactly the increase in the soft tissue is about 3.5 millimeter distance from the soft tissue margin. And then there is the concavity. So it's the opposite. We like women that have the convexity in the right position, not in the wrong position. So what we have to decide is where is nice to have the convexity and where is nice to have the concavity. Otherwise, I cannot believe that we say we make bone augmentation, buccal bone augmentation for aesthetic reason, because everybody knows that the bone starts about 3 millimeter distance from the cement enamel junction at the buccal aspect of a very, very nice tooth. So when we have bone, and we know that there's some bone that have been lost, we have to decide how much bone we want to regenerate. We want to regenerate to the white line. It's called shallow, or it's called shy regeneration. Very, very shy, like me. Or straight, or the exact line that continues the bundle bone of the true adjacent teeth. The red line is exactly the same curve that continues the bundle bone. Bundle means that it's there only because there is the root. Otherwise, socket shear doesn't mean anything at all. And then there is the green line. Green because of speranza. Why? Why do you have to augment the bone there? Why? Is the bone ever been there? Is the bone ever been there? This is the level of the bundle bone. This is the level of the bundle bone. This is, I don't know. But the problem is that if you ask people why do they do this, he's saying, oh, because it's going to resolve. But they use not resolvable material to do this. Or if you ask, they do it because of aesthetic reason. Aesthetics? Is this aesthetics? Because the problem is that now I have to cover this. And in order to cover, what happens to the soft tissue? The soft tissue suffers. Because the whole space for the soft tissue, the whole space means the possibility of the soft tissue to increase in thickness, it's occupied by enormous amount of materials below. And so suffers, and so what happens now is that maybe you have bone, which is not bone, but the problem is that you don't have any more of the tissue. So does it make sense? Sorry, to go back, sorry, no. It's too much, sorry. Does it make sense to get from here, in terms of soft tissue, because of the need to cover this with a lot of muscles, the old tissue, the old thickness is lost. So does it make sense to start from here and to get there in order to have bone that never been in this patient? Since we know that aesthetics, at least in the first 3-4 millimeters column, depends only on soft tissue and not on the bone. And so the question is, does this really make sense? And now, if you go back to our patient, and when you see that there is some patient that unfortunately have this problem, because this is a problem when it's a patient with teeth, and it's such a problem that when we see such enormous amount of bone at the buccal aspect of our teeth that is covering the teeth up to the cement enamel junction, and the whole suprabony component of the root disappear, what do? We take a diamond burr and we remove the bone. So, this is really strange for me to understand why in the case of teeth, also Andrea, you know, make a lot of plastic. Also ostectomy, in the case the bone is too much. And when we speak about implants, we want to increase the buccal bone, where bone was never. And when bone is there, is because of something that goes wrong. And it's called altered pulse corruption, gamma smile, something that is not so nice from an aesthetic point of view. So it's really strange. In my opinion, this is really strange. What we want to achieve around the implant is something that we don't like in terms of teeth. And so, what we want to do in terms of teeth is exactly the opposite. To reduce the thickness of the bone, to expose the root, in order to expose the suprabony component, so without making any root planing, so the gingiva can attach with the connective tissue attachment to the suprabony component of the root. So we have to decide what we like, dear friends. And I absolutely believe that what we should be able to resemble as much as possible is the aesthetic appearance of the patient as it was before. So if you have a nano tooth like me, very, very short, nobody like it. And so what we do is, if this bone is too thick, if it covers too much the cement-enamel junction, we start to make plastic in order to reduce the thickness of the bone, because we don't want to have too much thickness of the bone as the buccal aspect of the teeth. And then we make also ostectomy, and this ostectomy is done with the blade used like a chisel in order to expose exactly what we want. So the suprabony component of the root, because by exposing the suprabony component of the root, we leave only the soft tissue to be attached to the suprabony component of the cementum of the root, and this is exactly what we need in terms of aesthetics in order to achieve exactly what the patient would like to have, because this is considered, at least today, nice from an aesthetic point of view. So from this situation, so what we want to achieve in implant is this situation, what we like to achieve in teeth is the opposite. Can it make sense that we have a different concept of aesthetics when we speak about teeth or when we speak about implant? So if aesthetics is the same, I think that we have to work exactly in the same way. What patients like is to see the whole teeth, the minimum amount of tissue that shouldn't be too thick, and then the bone starts, where most of the patients do not have any awareness. 3.5 millimeters more distance with respect to the position of the soft tissue margin. And so now it comes the second problem. What we can do in the case of implant therapy in order to substitute this wonderful area, which is called suprabony component of the root. This is the problem. The problem is not the buccal bone, dear friends. If there is the bone, it's better because no bone, no implant. But how much is the buccal bone and where is the buccal bone is much more dictated by the position of the root in the case of root, or the position of the implant in the case of implant. What is very difficult to substitute is this area, which is about 3.5 millimeters distance. So it's a lot. It's a lot to say it doesn't exist. And so if you consider this area, and if you look what happens at the time, we can, yes, give support to the tissue in this area with something that is called temporary crown. But we know that the soft tissue cannot be attached to the temporary crown now, at the time of the surgery, and neither later. It cannot be connective tissue attachment in this area. And so in this area, we have to make fun of biology and make this area, which is nicely, because there is a distance between the ideal position of the soft tissue and the position of the implant that is much more palatable, together with the crown, which is much more palatable, to keep this area, which is perfect for what? For increasing the thickness of the tissue. We cannot do anything else. Two alternatives. Or you tell me, I keep also the suprabony component of the root and replace the implant, and I don't know what happens to this root if you keep also the suprabony component, or you have to place a connective tissue graft in the famous 3.5 millimeters area that correspond to the suprabony component of the adjacent teeth. So I don't think that we have so much alternatives, because only in this way we can give the tissue exactly the same, let's say, to be very, very similar to the adjacent root and soft tissue, even if there is no root anymore. So it is this, the critical area that we have to work on, and in this area, since it's not an area belonging to the bone, we have to work with by increasing the soft tissue thickness. So that the patient can smile a bit, can smile more, and whatever is the smile, everything is nice. Because the bone, which is more typical, should be concave, while the soft tissue, where the enamel gets out, should be convex. So now, the concept is, whatever is the situation, and whatever is the type of implant, the problem is no more the buccal bone. Yes, if you don't have the buccal bone, you will restore the buccal bone to the ideal position of the buccal bone, which is very, very similar to the ideal position of the buccal bone of the adjacent tooth. That is 99% of the teeth you're going to treat in the aesthetic areas. But the problem is that this area, which is so nice to give support to the soft tissue, because we have connective tissue attachment, is not present at this side. How can we give support to this area? We can use suprabony component of the implant, we can use abutment, we can use subgingival portion of the crown, yes, but whatever it is, we cannot achieve the same quality of attachment that is present here. And so we have to increase the thickness of this area so at the end of the surgery, the two teeth, natural and implant, is exactly the same. But what we did at this level during the surgical procedure, it's something that is very, very important, is to place a connective tissue graft that coinciding exactly with the position of the suprabony component of the root of the adjacent tooth, which is our goal, the homologous natural tooth. And dear friend, the connective tissue graft is placed so corner, because it's very corner, the distance between the cement enamel junction and the buccal bone, that I think personally that it's very difficult to establish the position of the connective tissue graft in this perfect position without elevating the papilla, because as you can see, by elevating the papilla, I can place my connective tissue graft exactly in the same position of the suprabony component of the root of the adjacent teeth, but thanks to the advancement of the flap, I can use the anatomic desepithelialized papilla towards the more palatal position in order to cover this graft. Otherwise, this graft will never survive. So I really think that, yes, there is many streets to go wrong, but there is only one street to place the connective tissue graft in the right position. This is by making coronally advanced flap. Because I want to be sure that the connective tissue graft is not at the level of the bone. If there is bone, I don't need the connective tissue. The bone should be where there is the root at the level of the adjacent tooth. In order to be so precise, this should be placed at the level of the suprabony component of the adjacent teeth. In order to be so precise, I have to see the papilla, I have to place the connective tissue in position, and I need some more papilla, more corona, which is in truth more palatally, in order to cover the connective tissue graft. And I personally believe that there is not so many streets to go to Bologna. So this is the situation of the patient at the beginning, and the whole job that Andrea described to you is always done by Dr. Monaco, that is my restorative dentist, so everything is planned before, including the change of the adjacent teeth, the treatment of the altered passive eruption, the extraction of the root, the displacement in the right aesthetically and prosthetically guide position of the implant, but now we need also to make the surgery. And when we make the surgery, we have to have really very clarified what we have to do. So we have to advance the flap. Why we have to advance the flap? Because we have to cover the connective tissue graft that should be placed in the right position in relation to the suprabony component of the root of the adjacent tooth. So very corner. And in this position, I have to make the papilla completely free. By elevating my flap, I will make my root extraction, even if this is very complex, much less traumatic for the soft tissue, much less traumatic for the buccal soft tissue, for the interdental soft tissue that has already been separated by elevating a buccal flap that is exactly the same type of flap that is used in order to treat multiple gingival recession, because this patient has also gingival recession, but has also some teeth that were treated for altered passive eruption, and so the bone has been recountered osteoplastic endostectomy in order to give the right distance between the buccal bone and the cement enamel junction. By guiding implant installation, we can reduce as much as possible the risk of making mistake, and the great advantage is the possibility to place a temporary crown that is already ready at the time of the surgical procedure, as Andrea was saying to you, which is exactly done at the same level of the adjacent natural tooth, but in that area, that at the level of the adjacent tooth, we have the suprabony component of the root. This is slightly more concave area because this is the nice area for the connective tissue graft application at the time of the surgical procedure. So this is exactly the same now, but in one tooth we will place the connective tissue graft, in the other tooth we don't need because there is the connective tissue attachment. So this is how it takes time, few minutes to rebase the implant supported crown, still retained at the time of the surgical procedure, because at the time of the surgical procedure, we need the temporary crown. Why? In order to give stability to the connective tissue graft, we need the suprabony component of the root at the implant side, but also we need the enamel. The enamel, so the convexity, it's critical in order to displace the corneal advanced flap in a more corneal position with respect to the connective tissue graft. Otherwise, the connective tissue graft is left exposed. And if you leave the connective tissue graft exposed, you have to pray that it survives. And even if you pray, even if it survives, it can survive with a different color, texture, and surface characteristics with respect to the adjacent teeth. And the best way, or the easiest way, most probably, is really to fix the connective tissue graft to the corneal advanced flap, so we are sure that once the flap will be advanced more than the ideal position, the connective tissue graft will also be advanced because it's linked to the inner aspect of the flap and will reach exactly the position of the suprabony component of the root of the adjacent tooth. So now we have tissue that substitute the suprabony component of the root, and now when we can insert the crown, from an external point of view, this seems exactly to be a natural tooth, but we know that this tissue is much thicker than this, because the crown leaves the tissue for the increase in the soft tissue thickness that was gained thanks to the adjunct of the connective tissue graft. And so we can give our patient the aesthetic satisfaction that most probably most of our patients, independently if they are women or men, really deserve. So I never start to mention the name of the patient because I never remember the name of my patients. But there is one patient that sometimes I can remember, and the reason why I can remember, you can understand. So this is Francesca. It's the only patient that I know the name. And the problem of Francesca obviously was nothing, no problems at all. There was some problem only in this area. And this is really, yes, it's not such a big problem. I know what you think, man, I mean, but you know, for us, it's the only thing that we can do to improve this smile. So when you look at this smile, you can understand that a lot of mistakes have been done. And this is because there was no planification, there was no diagnosis. And can you see this very short tooth as a natural tooth, this short tooth as a natural tooth? So before placing an implant, you have to be a periodontist, you have to be a dentist, and knows that if there is altered passive eruption, which means that there is one tooth that is too short because there is too much bone, this has to be increased in length before deciding where to place the implant. Because yes, we know that the implant should be placed at the right distance, about 3.5 millimeters distance from the soft tissue margin of the homologous tooth. But if the homologous tooth is wrong, you cannot place the implant. Because in this case, the implant was placed exactly 3.5 millimeter distance from the soft tissue margin of the adjacent tooth. But what was the problem? That this was not the correct position of the soft tissue margin of the adjacent tooth. So in this case, I can see that we really have the all mistakes that can be done in one patient. So not the right diagnosis, not the right treatment because of the wrong diagnosis, and not the right planification, because I have to know at least where is the ideal position of the soft tissue margin before deciding to place the implant. And now the problem is that compared to the position of the cement enamel junction, the head of the implant, it's about at the same level of the cement-to-enamel junction of the ancient tooth. And we know that this implant should be about 3 millimeters more apical. So the biggest mistake you can make is not to deep the implants too much, not enough. Too much is also a mistake, but not to deep the implant enough. So in this case, I think it's summarized more or less what I tried to share with you in this time. So what we have to do in teeth and what we have to do in implants is more or less the same. So we have to create a suprabony component at the level of the teeth they don't have because they are in altered passive eruption by making a osteoresective surgery. And this osteoresective surgery is made of submarginal incision, it's made of osteoplastic, and it's made of ostectomy in order to remove the bone, covering the root too much, in order to expose the suprabony component of the root. But it's also true that in order to place the implant, we have to consider that the suprabony component of the root cannot be maintained. And so in this area, there is no other way to keep the soft tissue be or resemble as much as possible the same. We have to increase the soft tissue thickness. So this is part of the surgical intervention that you have already seen. We can decide, especially for young people, I absolutely agree with Andrea that for people that has less experience, we can guide our incision design with some surgical guide, which can be used, unfortunately, only in those cases in which we have a lot of keratinized tissue. Otherwise, we have to achieve much more experience and then treat only the cases with less amount of keratinized tissue. And this submarginal incision, it's not so critical for the aesthetic outcome. What is critical for the aesthetic outcome is how much we will be able to remodel the bone in the right position from the cement-to-enamel junction of each of the teeth included in the flap design. This surgical procedure is done by making split thickness elevation of the papilla that at the level of the implant site have also another very, very important role. Because yes, it's true that I have to apically position the flap at the level of the teeth with too much bone, too much gingiva, but it's also true that I have to try to increase the thickness of the tissue at the level of the implant site, because at the level of the implant site there is no more the suprabony component of the root. And can we join the two procedures? Yes, we can, because we are using a technique that is called coronally advanced flap, that by exposing the bone crest at the level of the adjacent teeth, by giving us the possibility also to make osteoplastic, to make ostectomy, but only site-specifically at the level of the implant site. What we can do is to add a connective tissue graft and to advance the flap in order to cover the connective tissue graft where at the level of the adjacent teeth we expose the root. And when we make this procedure, we have to keep the papilla in position, because this was not the topic of today, but obviously the papilla is one of the most important areas where the patient is aware if something goes wrong. And so if we want to get the best aesthetic, we have to keep the papilla in position. We have to reshape this papilla by making the desepitalization of this papilla with very, very small microsurgical scissors in order to give them the very, very natural triangular shape. Now we have to check the bone, and if there is no enough bone exposure, we have to increase the bone in order to place the buccal bone at about 2.5 to 3 millimeter distance from the cement-to-enamel junction, reducing the bone thickness. But please don't make root planing. What we are doing is to expose the root cementum by removing the excess of bone where bone should not be, but we have to leave the root cementum into which the gingiva with its connective tissue fibers can insert, remineralize into the root cementum and create again connective tissue attachment. So yes, ostectomy, yes, osteoplastic, but no root planing. No root planing unless we have to make some more apically position with respect to the cement-to-enamel junction for restorative reasons. So now we have to make also the treatment at the implant site, which is very important also to increase the length of the canal. The canal is too short, too much bone. Somebody made bone augmentation maybe at the level of the canal, so we have to reduce the bone. I was joking. Nobody made bone augmentation at the level of the canal. Bone was put there. And then I like to use the blade as a very, very small chisel, because if you use a chisel, this is so flat that it's very difficult to reshape the bone crest to be completely parallel with the ideal position of the cement enamel junction at about 2-3 millimeter distance. And it doesn't matter so much if it's 2.5 or 3. What is important that is you don't make root planing. You don't have to make root planing. Because if you make root planing, yes, now you have a pathological root, where, yes, you can also achieve connective tissue attachment, but most probably you have to make also some amelogenesis treatment, you have to give great stability of the blood clot, which is not so easy to be achieved with an apically positioned flap. It's easier to achieve with a coronally advanced flap. But why do we have to remove the cement? We have to remove the bone. We like the cement. We like the cement, but we don't like the bone, where the bone should not be so too much close to the cement enamel junction. Now we have to substitute the lack of the suprabony component of the root that was exposed at the level of the adjacent teeth with the connective tissue graft. And the reason why the connective tissue graft in this case was extended also to the central, it's very, very cosmetic, unfortunately, is because in the profile, if you increase the thickness at the level of the lateral, it risks that the thickness at the level of the central is not thick enough. So yes, sometimes we can also do something only for cosmetic reason, and it's small compromise. But the most important thing in this case is that the connective tissue graft should be placed at the level of the implant, exactly where we have suprabony component of the root at the level of the adjacent tooth. And despite this, since I am able to advance the flap, I still have papilla disepithelialized into the palatal aspect that I can cover with my coronally advanced flap. No coronally advanced flap, no party. So now I can stabilize my graft in the exact position that corresponds to the suprabony component of the root of the adjacent tooth. I think I said sometimes suprabony component of the root today. I want to give one message to you. Suprabony component of the root. This is my goal for the next 2 years before retiring. Now, everything is able to be advanced coronally at the level of the lateral, where we have the implant side, and apically at the level of the adjacent teeth, where I did osteoplastic ostectomy and exposure of the suprabony component of the root. And obviously the hand was nice, otherwise I will not show you. And this is after years that you can see how this tooth was really rescued, but most of the treatment was not done on the implant side, was also by exposing the suprabony component of the root of the adjacent teeth that made the soft tissue very, very similar. And the adjunct of the connective tissue graft also on this side was so that in the smile, but especially in the profile of the patient, you don't see so much difference, because the root of the canine is much more buccally displaced than the root of the central, and so they keep the tissue in this position, but the lateral lack of the suprabony component of the root. So my take-home message, that's my take-home message. Don't forget, there is a suprabony component of the root, not only the infrabony component of the root. The infrabony component of the root, it's important to keep the bone. And then you will decide if you need this bone or not. But it's not for aesthetic reason that you have to keep the root, because what is lacking is this, the suprabony component of the root. And this is extraordinarily important at the level of the teeth, because we have connective tissue attachment. The soft tissue, even if it's thin, it's attached, strongly attached to the root, thanks to the presence of connective tissue fibers. So how can we solve the problem in the case of the implant? We have to measure the thickness of the soft tissue at the implant side, and look, it seems quite thick, but it's no more than 0.7. What does it mean? It means that the thickness of the tissue in this level should be more than 2 millimeters. And so exactly in that position, we have to add a connective tissue graft that, by matching the thickness of the flap, the thickness of the connective tissue graft, and the temporary crown immediately applied, will be able to compensate and give the final shape to the soft tissue that we like to see in our daughter. Thank you very much for your attention.